Welcome to the Proactive Security Podcast with Mike Hodges and Brine Hamilton. This podcast is dedicated to discussing violence prevention in healthcare. We want to inform, equip, and empower healthcare security leaders to prevent violence before it happens. And now, here's your hosts, Mike and Brine.
Hey everybody, I'm Mike.
And I'm Brine.
And this is the Proactive Security Podcast, Episode 2.
Thanks for joining us today. As always, we appreciate everyone who listens to the show. All right, before we get started today, Mike and I just want to take an opportunity to recognize all of our frontline security professionals who are making a difference, not just in terms of preventing workplace violence, but just in the everyday work that you do. And we just want to make sure that we recognize you and take advantage of Healthcare Safety and Security Week to do that.
Yeah, I think one of the amazing things, and people really get this, don't see this enough. One of the amazing things about healthcare security professionals is we have the opportunity to enter into people's lives in their worst possible moment and make an immense difference. And our frontline officers do that every day, no matter the facility they're in, the size, the location. Frontline security officers make a tremendous difference in the lives they touch. Oftentimes, like I said, at the worst possible moment in that person's life. And that is an honorable pursuit. And it is amazing the way that they do that around the world. And so awesome stuff. We need to celebrate it more than 1 week a year, but I'm glad we can focus on it right now.
Today, we're going to discuss the proactive approach versus the reactive approach to workplace violence prevention in the healthcare environment. So, Mike, we've talked about this before in the past, and we've discussed the need for the proactive approach to workplace violence prevention in the past. And there's a lot of ways to work towards accomplishing this approach. I want to explore your take on this because you take a very holistic approach, starting with the physical security measures. So let's start there. What's your approach in terms of the physical security aspect?
I think that's a great question, Brian, but I want to back up for just a second and let's talk about the need just one more time, because I don't think we can underscore what it means to be proactive in a security environment enough. And when we talk about proactive versus reactive, what we're really saying is that we want to stop something before it happens versus respond to something after it happens. And we mentioned this a little bit last time, and certainly we've talked about this in the past. But when we're reacting to something, the fundamental issue there is, especially when it comes to workplace violence, someone has already been assaulted. We already have an act of violence that we're reacting to now, instead of proactively working towards the prevention. And I think as security practitioners, as security leaders, we really have to start changing the cultural mindset around workplace violence in particular to preventing things before they occur. What does it mean to be proactive? It means to prevent before it occurs. And there's lots of different ways to go about that and utilize the knowledge that we have to take preemptive and proactive action. And a good place to start is our physical security environment, because if we create a very poor physical security environment, well, then we're opening the door to so much more vulnerability. And so I think there's lots of different ways to talk about it, but I want to start with that real clear understanding that being proactive means taking that action ahead of time, and physical security planning is a big component of that. When I think about physical security and how we utilize it to be proactive, I think about several different things. So you can get real high-minded with your criminological theory, and we could talk about things like the broken window theory. And we could dive into SEPTED or crime prevention through environmental design. And I think there's good aspects of all of that. Certainly there's the broken window theory has its proponents and its detractors. I think there's a core belief there, though, that I think is still good. And for those that don't know, the broken window theory is really about maintaining the appearance of a high security environment, whether it exists or not. But in making sure that we're fixing things like broken windows, I think, to me, when I think of that broken window theory, I think about taking positive action and regular action to maintain our physical security measures effectively. So are we constantly checking to make sure that the locks on the doors work, that the cameras are functioning, the alarms are enabled. Those types of things from a physical security standpoint, are we staying on top of the preventative maintenance, the routine maintenance, the break fix maintenance, all of that, so that we can rely on that physical security system to function well. And then, through, crime prevention through environmental design, are we designing facilities that are going to promote or eliminate security issues? And in a healthcare environment, we have a real challenge with designing physical environments that prevent or work towards the prevention. And oftentimes we design environments that are actually detrimental. One of the things that we struggle with is creating these just perfect little boxes for people to get trapped in all the time. And we see people in workplace violence scenarios where they get stuck in the check-in desk, or they get stuck behind the little desk that they've set up for checkouts at a physician practice, or for financial counseling at the hospital, or for whatever it might be. They create these little boxes that people just get stuck in. Triage rooms are notorious for this in emergency departments. You build these tiny little triage rooms because it suits capacity and it suits the clinical needs, but it creates this little box that no one can get out of when someone decides to go the wrong direction with their behavior. So I think from a physical security standpoint, those are two kind of key fundamental theories. And I'll add to that one more thought process that I'm really passionate about, and that's what I call proactive patrolling. And there's lots of different terminologies for that, but that's how we utilize our officer staff. Are we utilizing our officer staff to keep constant awareness and focus their patrol areas on a daily basis based on our operational need? And I'm thinking about operational need in terms of multiple factors, but the number and location of high-risk patients in the facility at any given time. Are we rounding on those individuals? The number and location of criminal activity. Are we keeping tabs on reports of crime around our facilities so that we're abreast or aware of the incidents that are occurring? And are we patrolling based on what we see? If there's a rise in entering autos in and around our facility, well, then are we stepping up our patrols in our parking areas in conjunction with that? And then, any kind of identified security vulnerability associated with that. Are we focusing our physical security assets from a personnel standpoint to meet that need and to make sure that we're minimizing the vulnerability associated with that?
It's funny, the one thing that you kind of touched on too that's been coming up a lot in the conversations I've been having is just how you're using security with the rounding and actually having them engage with the staff. Is that something that you've kind of implemented in your practices as well?
Absolutely. When we talk about proactive patrolling, the fundamental key to proactive patrolling is staff engagement. And so, when we talk about proactivity too, one of the things that we really talk about is a clinical integration of our security staff and our clinical staff and the way that we treat the patient holistically. We talked about this last time, and I'll talk about it again. We'll probably talk about it again the next time, and so on. This topic will just come up. It is what it is. But the scope of workplace violence in healthcare, it is what it is in large part because of the disease progression that brings out the violent issues that we see. And so we have sick patients and their diseases progress in such a way that we see acting out behavior associated with that, which may take the form of cognitive impairment, different forms of altered mental status that are going to produce the kind of confusion that people react to in a violent way. And so we have to look at workplace violence prevention from the standpoint of clinical integration. How do we bring to bear our security resources in such a way that we support our clinical staff effectively in the treatment of the patient so that we can reduce the acts of violence? And so that starts with proactive patrolling. When we identify a high-risk patient, well, great, we now know that this individual is high risk. Let's talk about the why. Let's have conversations with the nursing staff. Let's meet at the bedside. Let's meet at the nurse's station. Let's round on that patient. And as we round on that patient, it should be a discussion. Hey, nurse so-and-so, tell me more about what's going on. Has there been any change in behavior? Is there any issues with the family members? Is there any issues with the treatment? What's the doc saying about prognosis, and how are we going to change treatment, and what's the discharge plan? These are all things that we should be integrating into our knowledge about the patient from a security perspective.
Right. I think another thing too, and I'm going to sound like a broken record to anybody who listens to the Healthcare Security Cast, but I think Also, there's an element of just really integrating your team in other ways, even just with staff training and staff education when you have those orientation sessions with new employees. I know that's something that I've always had the privilege of being involved in. So you really put a couple of faces to that security department, so people know who they can talk to when there are these type of challenges or things that could potentially go sideways. You have that relationship already, so people feel comfortable approaching you with that. Is that something that you focus on as well? Do you do anything as far as orientations or education throughout your facilities?
Yeah, I'm glad you brought that up. I think, another part of proactivity is your education plan. So, how are you teaching people de-escalation skills? How are you teaching people about the scope of violence and the root causes of violence in a healthcare environment, and preparing them to know what escalation looks like when they see it, and then respond to that escalation accordingly? And that can take multiple pathways, not only their individual de-escalation skills as a nurse, as a patient care tech, as a secretary, as a front office assistant, whatever their role might be, giving them the skills to do de-escalation, but also to know when the escalation is moved beyond their ability to engage. And now, what are the tools available to me as that front office assistant, that nurse at the bedside, that patient care tech, that patient transporter? What are the resources available to me in my organization to call on to help me take the next steps to be proactive? Whether that's calling for a threat assessment, calling support to de-escalate, and whatever the case may be, what resources do we have? Do I know about them? And through that education, I should now know about them and know how to access them to take action for my own safety and for the safety of others.
And the other thing too that you kind of made me think of there is the whole concept. CPI, the nonviolent crisis intervention training, talks about this, about not being a trigger, understanding yourself in that situation, and what your biases may be or what's impacted your day, as well as Vistelar's training. They talk a lot about non-escalation, so the things that you can do before somebody escalates. So one of the common things that I've seen working in hospitals are that some of the, well, I was going to say clinical staff, but it's security staff as well. You see so many of the same types of things coming through the door that maybe you become kind of numb to it. So somebody who's had a reason that's brought them into the hospital, into the emergency department, for them, this is the first time that they're going through this. For you, it's the fourth or fifth time that day.
Yep.
So, you can be kind of insensitive in your responses, and those are some of the things that can trigger people as well. So another thing that we need to be mindful of is even before people escalate, just knowing how we can avoid that. So that whole kind of concept of non-escalation, I think, is another important piece as well.
I think that's huge. And one of the things we talk about in our education programs all the time is relationship building. The key to de-escalation is the ability to build relationship. And how do you build trust in the context of relationships so that you can communicate effectively, and people can, in what is potentially the worst moment of their life, relax in so much in their ability to trust you to handle this issue effectively so that they don't escalate further. And I think that's a fundamental, and CPI does that well, Vistelar does that well, and helping us understand that our first mode of de-escalation is relationship building. How do we build a relationship with this person?
Right. I think one thing too that I'll go back to is, I'm going to quote Martin Green. Martin Green always likes to highlight that, nobody really wants to be at a hospital unless they're having a baby. And, even in those situations, things can go wrong. People unfortunately lose a child at birth. And then there's the other human factors that become involved where, a husband's there with his wife, the baby's born, and then the father of that baby ends up showing up, and you have a dispute. I remember there was one of the hospitals I worked at. We actually had a situation where there's someone who was a regular visitor to our hospital because of the work they did. So there's a good person who was serving the community, and his wife was having a baby. So we were, as the security guards, we were providing the access in that emergency department so he could get through to the labor and delivery. The thing was, this couple, both of them, they were Caucasian. The baby was born, the baby wasn't. So, so again, there's all these situations that can still happen.
That's a telltale sign. Yeah.
Yeah. Usually, usually there's an issue when that tends to be the scenario, right? But those are the situations where things can potentially escalate. Like, fortunately, in this situation, it didn't. But you do have things like that do happen. I've heard stories of people getting into physical altercations over family members like literally over a family member who's dying, over who's going to get the TV, things of
Oh
that
yeah,
nature, right? So you have all sorts of things too that, that we have to consider. And just keeping in mind with every person that you deal with, there's a very good chance that they don't want to be at the hospital. So kind of keeping that in mind with all of your interactions.
very true, very true.
In terms of proactive planning, we've touched on a couple of things, but you've shared the concept of predictive violence risk assessments that enable proactive planning. Can you share some of your learnings and tools that support proactive planning in terms of violence prevention?
Yeah, I think one of the things that I said last time, and when I started the Proactive Security blog, I started with a series on violence risk assessments, and I was talking about clinical violence risk assessments that are done at the bedside by clinical staff. And there's lots of different versions out there, but what it was, and what we're talking about there is we talk about a violence risk assessment, and that term is we're talking about an assessment that gives us predictive value of potential risk, of the potential escalation of that individual. And so there's lots of different tools out there. There's kind of three main ones that I talked about in the blog series on it was the STAMP tool, the BROSIT violence checklist, and the ABRAT, the aggressive behavior risk assessment tool. And all of them are good and present value. So I wouldn't promote one over the other. I think some are better for different environments. The STAMP tool and the BROSIT tool are kind of short visual assessments. We take kind of a visual stock of the behaviors that we're observing in a particular individual, and based on that assessment, we can produce some level of predictive value in there in a short-term window. So within the next 24 hours, these are relevant risk assessments. And then the ABRAT is a much more in-depth version of that. Still a very quick and effective assessment, but looks at 10 to 17 points of inquiry based on not only the things we're observing in an individual, and so the behaviors that we see that may cause us to predict a certain amount of violence or potential for violence, but also the medical condition associated with that. So, a tool like that's better for med-surg floors and inpatient units within a facility. But in every case, in the research that I've done and what I've seen play itself out in my own facility, is a significant predictive value and significant reduction in violent acts based on the knowledge, right? So one of the assessments, bedside risk assessments or violence risk assessments, when done from a clinical perspective, provide kind of two key opportunities for us. One, they give us that value, they give us that risk value and say, hey, this is a high risk, this is a medium risk, this is a low risk, this is how much we should pay attention and how careful we should be around this particular individual. That is a huge value. Being able to predict effectively is tremendous value. The second thing, and this is something that I think people miss sometimes when they talk about assessments like this, but to me has just as much value as being able to say this person's a high risk to commit an act of violence, is they promote preemptive or proactive conversation. And so, when a nurse completes a falls risk assessment, right? When they assess a patient for their potential risk of falling, well, then they start having proactive discussions with the other clinical staff to say, hey, this patient is a high risk for falling, so let's make sure we put all these extra protective measures in place to make sure this patient doesn't fall in our facility, and they're protected from that. We don't want them to get up and wander through the hallways by themselves because they might fall. In the same way, a violence risk assessment presents us with the same opportunity. So now we have a clinical staff member assessing the risk and saying, hey, this individual has a high risk for violence. Based on that high risk for violence, let's start having some proactive conversations, not only with the other clinical staff, which is awesome, but also with our security partners who present value in that, with that de-escalation expertise and the ability to help mitigate the potential acts of violence. And so those two opportunities alone make a violence risk assessment tool extremely beneficial. And the clinical side of the assessment process makes it so much more integratable into the process. We can plug tools like that into our electronic medical records and use them through automated processes to really just be incredibly effective, and connect them further within the EMR, within the electronic medical record, to flag and set up alerts associated with the nature of the level of threat, which also has benefit for our ancillary staff. It helps us communicate to a wider audience about the potential risk with that particular patient, which is huge. So, some of the studies that we looked at, and this is especially relevant with the Brocet had just tremendous research behind it, and I highly recommend people take a look at that. They have their own app, so you can assess violence at will via the app. I mean, what's not to like? But they did multiple studies, and they had a study in 2008 where they saw like a 41% reduction in violence. Another study in 2011 saw a 68% reduction in violence. A study in 2015 saw a 48% reduction in violence. I mean, it just goes on and on with the amounts of research associated. You're talking about huge numbers, 41%, 68%, 48%. This is an incredible demonstration of the value of reduction in violence based on the use of that predictive assessment. And it's because we're having interventions ahead of time. The other part about that the violence risk assessment, the clinical risk assessment is it brings attention to any kind of change in the patient's condition. And so, a lot of times what we already talked about is that clinical progression of the disease. Well, if the disease progression is going in the wrong direction, if we're seeing this patient gets worse, oftentimes that's expressed through some of the violence we see that might not otherwise be categorized in a clinical way. And so we get an opportunity not only to provide the predictive value for the protection of our staff, but we get the opportunity to make the patient better because we've identified deterioration in the condition as well. And so tremendous value, right? Tremendous value in a clinical risk assessment, violence risk assessment. The other side of that coin is we don't have to wait for clinical staff. Integrating something like a clinical risk assessment into our clinical practice in a hospital or healthcare facility is a big deal, right? That takes a lot of work. It takes a lot of discussion. It takes a lot of parties at the table making decisions. Well worth the investment of time. But we, from a security perspective, can bring value in that way as well by utilizing tools like the security threat assessment that we use at our facility, which is another kind of bedside assessment, but it's something that we drive instead of the clinical staff drive. So when we see a continued issue with a patient, we see an issue that's also relevant with family members. We often know in healthcare facilities, it's not the patient that is the problem, it is the family member that's a problem in some way, shape, or form from a violence perspective. You talked about the family members fighting over the body of a patient. I've seen that myself. You have the opportunity to see some of the best in human behavior, and you have the opportunity to see some of the worst in human behavior. And I've definitely seen it wasn't the TV they were fighting over, but they were fighting over who was going to get what at the end of the day over the body of their loved one, which is just terrible. But you have the opportunity to use assessments like the security threat assessment, where we look at different things. And so we say, okay, let's have a quick discussion. And we can take a worksheet, simple worksheet, say, hey, nurse so-and-so, you seem to think there's an issue here. Let's talk about this. Let's have that proactive conversation, which is so important, so important, so important. I can't drive that home enough. You got to talk about the problem. So let's have that proactive conversation. Let's talk about, hey, what kind of disruption to operations are we seeing? What kind of acting out behavior are we seeing? Are threats being made? Do we know anything about the individual's history? Do we have a prior incident history in our own facility? What are some things that we can look at from a threat assessment standpoint? Say, hey, we see a low, medium, or high level risk here based on our discussions and our assessment of the subject, and let's take proactive or preemptive action to help support the reduction of violence, the elimination of the act of violence. And the great thing about all of these assessments, clinical violence risk assessment, security threat assessment, they happen before someone gets assaulted.
Excellent. Now, a couple of things that you mentioned in there as well. You talked about the different alerts. You talked about the app. Just a couple of technological things. Is there any other technology that you're using, or any technological trends that you see emerging that you feel would be helpful in the battle against workplace violence?
So, you could go a couple of different routes with that. One of the things that, I'm really interested in, and I think this is something that we're kind of lagging behind on, in the healthcare security arena is active and effective data collection and active and effective operational intelligence. And so, most of the time when we see people utilizing data effectively, and we see people utilizing operational intelligence in a way that's meaningful to change operations in an effective way, we see somebody who's really homegrown and put together with bubblegum and duct tape the best possible data scenario that they could, given the tools they had to work with. And what I'm hopeful in is we're starting to make the transitions as an industry. And I really do feel like we are in a very unique time as an industry. We're seeing kind of a huge cultural shift in our industry right now. And what I'm hopeful is we're seeing some of those tools come to bear that are going to be more effective. And, there's lots of different data collection tools out there, but we're starting to see the ability to access just mountains of data from our various electronic medical records and integrate those into our threat assessment capacity. We're seeing the opportunity to collect data in ways that we've never done before. Omnigo, you're connected with Omnigo. Omnigo, we utilize them for security incident reporting at our facility, and our ability to collect data within that software as our officers are making daily incident reports, putting in event logs and utilizing the dispatch is just incredible, as we're able to collect so many different points of data and start to put that data together in a way that gives us predictive capacity. And that's the point, right? We want data to tell us where we've been, right? And we want to know how things have worked from then till now. But the value comes when we can take what we know about what's happened from then till now and trend it and analyze it and tease it out in such a way that we can start to make assumptions that are effective about what's going to happen next. And that's where we start to target resources. That's where we start to change the nature of our physical security layouts. That's where we start to deploy officer assets, all of those things to help us be more effective and more proactive based on what we've seen that's happened in the past.
Right. And I think you're absolutely right. I think we're at a really unique time in the industry where there is a huge opportunity for us to take advantage of the technology that's available, especially in terms of reporting. One of the things that we've talked about, I don't know if we talked about it, I can't remember if we talked about it on the last episode, but the data warehouse project with IHSS.
Yep.
That's something that's going to be very helpful down the road. So yeah, agree. We're in a really good spot, and we have a great opportunity to do this the right way, and really be able to have a profound impact on the industry.
Absolutely.
One of the things that we've talked about before as well, and I know I've had this conversation with a lot of people, but you'll sometimes hear the narrative about workplace violence in healthcare just being people will say some things just happen. What are your thoughts on this approach?
Well, that's true, but that doesn't mean we shouldn't do anything about it. It's like, hey, man, some things just happen. That's absolutely right. People's houses get hit by lightning sometimes, but that doesn't mean we shouldn't install lightning rods, right?
Yeah, absolutely.
So that does not. It's interesting to me, the cultural issues we have associated with workplace violence. I think when you hear things like some things just happen, or that's just a part of the job,
yes,
or whatever, it is this just abject abdication of responsibility for the issue at hand. And I don't have a lot of patience for it in general, but I have to laugh when somebody says something like that. It's like, yeah, you're right. Some things just happen. But that has nothing to do with whether or not we are supposed to do something about it, or at least try. And when we're talking about somebody get assaulted at work, somebody getting murdered in the parking lot, somebody coming into a building and shooting it up, whether it's a slap across the cheek or a stab through the heart, these are acts of violence that are occurring to our staff. And just to say, man, some things just happen, is just the most ridiculous abdication of responsibility. We have a responsibility to protect people, and as security leaders, and I think anybody who's listening to this program has decided to be a security leader, whether it's formal or informal. You're taking leadership by seeking information from outside your own knowledge. And so I think, as security leaders, we have a responsibility to start fighting back against that thought process. If it's anybody's responsibility, it's ours, and we better own it first and foremost. We better own it as our responsibility. But two, we've got to promote that responsibility in others and lead people to that understanding because some things just happen, just doesn't cut it. We're talking about people getting hurt and potentially not even going home, and that's just not okay.
Right. And I think yeah, the thinking has to shift in kind of the opposite direction. Like, yes, some things just do happen. I'm a big proponent of sometimes there's just not a good alternative. You know, you can make all the right decisions and things can still go sideways. But I think it's for that reason, it's of the utmost importance that we do the necessary things to prepare and make sure we're preparing people for the work that they have to do. Yeah, I'm not a fan of the approach of, you know, it's just part of working in this environment is that you're going to be assaulted. No, it's absolutely absolutely ridiculous that we even, you know, that we even accept that kind of thinking.
Absolutely. Yep.
Great. Now, I think we covered quite a bit here. Is there anything else that we need to go over, Mike?
Man, you know, you get me started, and I'll just keep talking. But I think we put a lot out there. I'm really interested as people listen to this podcast that they start to engage, because I want to hear other people's thoughts. And I ask the question at the end of every blog that I put out. You know, how do you apply this in your facility, or what are your thoughts? I'm curious about people's thoughts on proactivity. When we try to make the distinction between being reactive and being proactive, you know, we're not abdicating responsibility for reaction. We've still got to be good at that. We've still got to be able to do that well. But, you know, this concept of shifting our mindset to being proactive as a primary means of prevention when it comes to workplace violence, I'm curious what people think about that. And I'd be interested to hear people connect and reach out, you know, comment, send us a message at the LinkedIn group or whatever that might be. Let's have a larger conversation.
Excellent. Yeah. And Mike has mentioned the LinkedIn group. So look for us on LinkedIn. It's the Proactive Security Podcast. So we do have Mike does have a page. Mike does have a group for the Proactive Security blog, and we have a page for the podcast. It's just a company page, but if you want to follow it, you'll get updates. You can connect with either of us on LinkedIn as well. And I'll give you a bunch of the tags here. So we've mentioned LinkedIn. You can connect with myself, Brine Hamilton, that's Brine, or Mike Hodges on LinkedIn. There's lots of ways to connect with us. We have this podcast. There's the Healthcare Security Cast, and the Proactive Security blog, which is proactivesecurity.blog. So be sure to check that out as well. Now, as we said last month, stay proactive. And if you're not being proactive, take this as the invitation to start being proactive. Take care, and we'll see you next month.
Have a great one.